Welcome, everyone, to our World Federation Societies of Anesthesiologists webinar, January 22nd, 2025. We will be discussing applying pediatric patient blood management principles to your practice. It is my pleasure to introduce our two moderators, Dr. Maria Echeto, who's a pediatric anesthesiologist from Honduras, and myself, I'm Dr. Susan Goobie. I'm a pediatric anesthesiologist from Boston Children's Hospital. So here's our agenda. We're going to have three speakers, three talks. First, I will lead with patient blood management is a global standard of care for pediatric blood health. Second, we'll have Dr. Heidi Meyer talk about anemia and the pediatric surgical patient. And third, we'll have Dr. Maria Echeto talk about implementing PBM in resource-limited settings, navigating the challenges. Some housekeeping items to start. We will love to hear and read your questions. And we will also be answering live at the end of this webinar. We will also be providing our answers in the chat. So please, throughout the presentation, feel free to submit your questions for us. And this webinar will be recorded and will be published on YouTube, and you will get a link sent to your email for the details of that.
So it is a great honor for me to introduce a pioneer in pediatric PBM, which is Dr. Susan Goobie. She is an associate professor of anesthesiology in Harvard Medical School and a senior associate in the Department of Anesthesiology and Critical Care and Pain Medicine at Boston Children's Hospital. She is currently in editorial positions that include executive editor for pediatric anesthesia and BGA. She also holds leadership roles on scientific research committees, and definitely she has published over 150 articles in the field, and she has done many lectures nationally and internationally, and I think there is no one that doesn't know all the wonderful things Dr. Susan has given to the PBM, pediatric anesthesia knowledge. So very much welcome, Dr. Susan. We are so happy to have you here.
Thank you so much, Maria. I'd like to introduce you, who you are a colleague and a friend. We've worked together with the WFSA on the pediatrics working group. And so Dr. Maria Echeto is a highly skilled pediatric anesthesiologist. She specializes in many things besides patient blood management, bariatric surgery, and management of cleft lip and palate surgery, and ensuring surgical safety for children in low and middle income countries. And she's really a leader in the field. She collaborates closely with many different foundations, such as the Little Hearts Project, the Friends of the Barnabas Foundation, and she is also the vice president of the Honduran Committee of the Society of Patient Blood Management. She's certainly a world-renowned leader in pediatric patient blood management. She's a speaker at many international meetings, and it's a pleasure to have her here today. And finally, last but not least, I'd like to welcome Dr. Heidi Meyer, who is a colleague and a friend. She's a pediatric anesthesiologist at the Red Cross Memorial Children's Hospital in Cape Town. She began her career in the UK, and then and she worked in St. George's Hospital and Great Ormond Street in London. And her research focuses on pediatric patient blood management, improving outcomes, and also she's a world expert in pediatric preoperative anemia, and she'll be telling us a little about the SAPSOS-2 trial. And it's certainly a pleasure to welcome. I'll get going with sharing my screen for my presentation. I'm assuming you can all see it well. So it is really a pleasure here. Thank you to the organizers for inviting me. And it's a pleasure to be with my panelists to talk about pediatric patient blood management. And I hope you'll all agree at the end of this webinar that patient blood management is a new global standard of care for pediatric blood health. So here are my objectives. I'm going to introduce the concept of blood health and patient blood management. I'm going to define the incidence and the reason for blood transfusion in pediatric patients. I'll review the benefits and risks of blood transfusion for the pediatric patient. I'll introduce specific patient blood management guidelines that I hope you can apply to your practice. And I'll discuss my 5 perioperative rules of patient blood management. So I'm sure you've all heard about heart health, liver health, kidney health, and gut health. But have you heard about blood health? Many more patients and families are aware of this concept. Blood carries oxygen from the lungs to all the vital organs of your body. It carries metabolic waste for elimination through the kidneys, carbon dioxide for removal through the lungs. It's really an important part of the immune system. It helps protect your body from disease and infection, and blood contains an elaborate system to stop bleeding and avoid clotting. It really is the river of life, an indispensable part of the infrastructure of your body's systems and life processes. An organ is a group of tissues that performs a special function, and the circulatory system and the blood it contains is the largest organ system of the body. Therefore, when you think about it, blood is the body's liquid organ. Like any other organ or system in the body, its balance and health must be maintained. We all know, as I've said, that blood has many functions, including maintaining the delicate balance between hemostasis and thrombosis. Suboptimal blood health can manifest as anemia, coagulopathy, bleeding, and thrombosis, besides many other pathologies. And it's this suboptimal blood health that can compromise outcomes for our patients, especially those in hospital undergoing surgery. The default treatment for anemia and blood loss is commonly a blood transfusion, which is essentially a liquid organ transplant. And perhaps we need to reframe our thinking so that blood transfusion is not the default. There's no doubt that blood transfusion can be life-saving. Why are blood transfusions given in hospitals? The reasons are listed here. Acute blood loss, severe anemia to restore oxygen delivery to vital organs, for volume to treat hypovolemia or hypotension, to treat a hemostatic derangement, or even to treat a laboratory number. And children in our operating rooms are being exposed on a daily basis to blood products during major surgery. This shows the US practice over the last 5 years. It shows the percentage of episodes transfused by surgery type. The highest categories include cardiac surgery, with up to 100% of infants who have cardiopulmonary bypass being exposed to blood products. Liver surgery, craniosynostosis surgery, scoliosis surgery are among other really high categories of surgery where patients are being transfused. There's about a 6% overall perioperative transfusion rate for non-cardiac surgery in our hospitals. And furthermore, 15 to 25% of patients that are admitted to our intensive care units are exposed to blood products. Let's consider the risks. Although improvements in hemovigilance have significantly reduced the transfusion-related infections, the reported incidence of serious hazards of transfusion or shot has increased, particularly in infants, with respect to non-infectious associated complications. And this table from 2022 lists the top reported categories. There are 2 cases of death reported for every 100,000 blood product transfused, and adverse reactions are up to 2 times more common in children than adults. We're giving adult blood products to our smallest, most vulnerable neonates, and it's likely that non-infectious hazards are under-recognized and underreported. The most important is TRIM, transfusion-related immune modulation, the depression of the immune system after an allogeneic blood transfusion, and it's associated with rejection, infection, and alloimmunization. And these effects of giving blood to our babies may have repercussions for the rest of their lives. In our recent article in Pediatric Anesthesia, we discuss error traps in pediatric patient blood management. And one of the most common pitfalls is failure to prevent unnecessary transfusion or failure to avoid overtransfusion. And in this article, we give some common guidelines to implement in your practice to avoid these common error traps. And I'll talk about these a little bit more in this talk. Patient blood management. Let's define it. It involves the timely, multidisciplinary action of application of evidence-based, multimodal medical and surgical concepts aimed at screening and treating anemia, minimizing surgical, procedural, and iatrogenic blood loss, managing coagulopathic bleeding, all through patient-centered decision-making and to commonly improve patient outcomes. That's really the goal. And this has been recognized by the World Health Organization. In its recent policy brief, The Urgent Need to Implement Patient Blood Management, the World Health Organization called for action to implement patient blood management to decrease the morbidity and mortality known to be associated with the transfusion of blood. And so here are some perioperative pillars of blood conservation in pediatrics. Some of our speakers, including myself, will talk about some of these modalities. We've broken them down into 3 pillars: preoperative, intraoperative, and postoperative. And I'm sure some of you are using these already in your practice. The question is, given that blood transfusion has a strong association with mortality, can we improve survival by leaning on the PBM pillars? And I think we need more research and evidence in that area. So here are my 5 rules of pediatric PBM. Timely anemia management, avoiding overtransfusion by using restrictive thresholds, implementing blood conservation strategies such as antifibrinolytics, employing optimal blood use by using goal-directed transfusion protocols, and treating the patient, not the number. And I'll take the remaining few minutes to go into a little bit of detail. Dr. Heidi Meyer will talk to us about anemia management next. I wanted to mention it because it's very important. Now more than ever, the global prevalence of anemia in children is over 40%, higher in lower and middle income countries, and iron deficiency anemia is the leading cause of disability among children. And it's a modifiable risk factor in adults and children. We have good evidence that anemia preoperatively is a strong predictor for blood transfusion and also is associated with adverse events with grade A evidence. And I'm sure Dr. Meyer will talk about that anemia is the problem, and the solution is to screen, if possible, 3 to 4 weeks before major elective surgery. If possible, to postpone to optimize patients if they are undergoing major blood loss surgery, to diagnose and treat anemia with an individualized approach. The second rule of patient blood management in pediatrics is to avoid overtransfusion by utilizing restrictive thresholds. The majority of hemodynamically stable patients with a hemoglobin greater than equal to 7, that red blood cell transfusion is not advised, especially if this anemia is chronic versus acute. In an actively bleeding patient, the target hemoglobin concentration is recommended to be 7 to 9. So there's no reason to go 10 or above. And that the post-transfusion goal should be a range between 7 and 9.5. And this is supported by evidence and expert consensus. The third rule is to implement wherever possible blood conservation strategies. I highlight antifibrinolytics. They are, I think, underutilized. We have good evidence that prophylactic administration of antifibrinolytics is recommended in neonates and children. And I would go even further to say it should be a standard of care if there's a high bleeding risk or a high potential for needing a blood transfusion. There are good pharmacokinetic based dosage recommendations for tranexamic acid. We published here in this article, indications should be the prophylactic treatment of bleeding in trauma or surgery with major bleeding, or even if minor or moderate bleeding is suspected, if the suspected blood loss is over 20% of the patient's blood volume. It is a clot stabilizer, not a clot promoter. So in many situations, very safe, has a good safety profile. And the dosage regime based on PK modeling is shown here. The fourth rule is to employ optimal blood use. That's giving the right product to the right patient at the right time for the right reason in the right dose. All hospitals who take care of pediatric patients should have pediatric-specific massive hemorrhage guidelines, which incorporate a massive transfusion protocol based on age and weight. It should be goal-directed and it should be readily available in a situation of trauma or bleeding. Here's an example of our Boston Children's Hospital Pediatric Massive Hemorrhage Guidelines. You can scan this QR code, and we've published this as well if you're interested. And it is really a goal-directed strategy to manage the child that's massively bleeding and is getting away, I think, from a fixed ratio approach, but it's using many evidence-based modalities for blood conservation, such as TXA, cell salvage, restrictive transfusion strategies, and viscoelastic testing if available. And the fifth is to treat the patient, not the number. Transfusion guidelines for all blood components should be weight and age appropriate based on laboratory and also physiological criteria and using restrictive thresholds and also blood conservation strategies. And that's very important because infants, neonates, and children are not just small adults. They have unique physiological age and weight associated developmental categories that we need to take into consideration. And some of those are listed here. I present to you a simple method to estimate circulating blood volume for your children based on age and weight. And we all should be calculating an allowable blood loss to give an estimate of what is considered a sort of a threshold. I usually look at 20% of blood loss as being a point where I'm going to get hemodynamic instability and need to start intervening and treating the patient. And even before that, blood conservation strategies are recommended. We should move towards goal-directed strategies. So that's considering the patient's hemodynamics, treating the symptoms of anemia or hemostatic derangements. We can use biochemical markers indicative of for sufficient end organ perfusion. And if available, cerebral and somatic oximetry is very helpful so that we're treating the individual patient, not just a number. Dr. Downey and I published some transfusion strategies based on this physiological parameters here in our article in anesthesiology. And so for a healthy, stable infant or child, if we look at some of the physiological parameters that are listed here on the left-hand side, which can be end organ saturation, oximetry, lactate levels, hemodynamics, such as blood pressure and severity of illness, then perhaps we can use these to go way above just using a number for making decisions for our patients, but really taking the individual patient and their physiological status into consideration. So to conclude, there's really 5 practical rules that I'll offer you for pediatric patient blood management. Don't ignore preoperative anemia and treat the patient, not the number. Keep the blood in the patient. Avoid bleeding into the chart. That's avoiding routine blood draws, which cause blood loss, iatrogenic anemia. Optimum blood use. Give the right product in the right dose to the right patient at the right time for the right reason. And I I urge you to take these into considerations for your practice. So preoperative anemia is a modifiable risk factor. We need to consider physiological differences in our pediatric patients. We need to implement restrictive transfusion strategies. There's really not a one-size-fits-all to a number, and we should also consider that red blood cell transfusions are to relieve symptoms of poor oxygen delivery to our end organs, not really to achieve a normal number. Avoid overtransfusion, and certainly think about blood conservation strategies for your patients. We need more evidence of efficacy, safety, and improved patient-centered outcomes associated with PBM interventions. And I think we can only do this by all joining together and collaborating in our research efforts. Here are my references, and I thank you very much for your time and for listening, and I look forward to questions at the end. It is now my honor to introduce Dr. Heidi Meyer, who will talk about anemia and the pediatric surgical patient.
Thank you, Susan. I'm just sharing my presentation. Okay, great. Thank you. Welcome to everybody, and thank you for the kind invitation and the opportunity to discuss this important topic, anemia and the pediatric surgical patient. My aim today is to try and shed some light on the burden of preoperative anemia and explore some of the challenges we face when trying to manage it in pediatric surgical patients. So this topic is of particular interest to me. As Susan has mentioned, I'm the principal investigator for the South African Pediatric Surgical Outcomes Study 2. And this is a pilot study we're running to look at the feasibility and clinical efficacy of preoperative iron in treating iron deficiency anemia in children undergoing elective non-cardiac surgery. And this study has been kindly supported by grants from the Society for the Advancement of Blood Management, the South African Society of Anesthesiologists, and the Pediatric Anesthesia Community of South Africa. Now, why is preoperative anemia in children important? Well, I'm going to try and answer this first by providing a brief overview of its etiology and prevalence. Then I'm going to discuss the pathophysiology of anemia and its impact on surgical outcomes. And finally, highlight the challenges and some potential solutions for diagnosing and managing preoperative anemia in children. To start, let's look at the global scale of the problem. There is no doubt that anemia represents a major global health challenge, affecting nearly 2 billion. That's a quarter of the world's population worldwide. And as Susan's mentioned, the burden is particularly high among children under the age of 5 years, and also in populations within sub-Saharan Africa and South Asia. And the primary contributors to anemia include dietary deficiencies, hemoglobinopathies, and neglected tropical diseases. We also know from the current literature that the high prevalence of anemia is also reflected in children undergoing surgery. As you can see from the chart here, preoperative anemia is really common, even in high-income countries like the US and Germany. But perhaps unsurprisingly, the current data suggests that the prevalence of preoperative anemia is even higher in low and middle income countries. And data from South Africa from the original SAPSOS cohort found that almost half of the children who had a pre-op HB recorded were anemic. But what we don't know at this moment in time is what types of anemia are contributing to this. So how many children have iron deficiency anemia? How many children have anemia of chronic disease or other causes of anemia? And this is a diagram highlighting the complexity and the key contributors to the pathophysiology of anemia. So I realize it's quite detailed, so I'm just going to break it down a little bit to look at the pathways involved. So as I've mentioned earlier, nutritional deficiency is one of the leading causes of anemia globally. Actually, as we've mentioned, dietary iron insufficiency is the most frequent, and it's a preventable contributor to anemia. And this nutritional deficiency is mostly due to dietary insufficiency, but can also be caused by issues with absorption of nutrients. And these combine to lead to absolute iron deficiency. Another important contributor is anemia of chronic disease or functional iron deficiency, which is driven by inflammation. Cytokines like TNF, IFN, and IL-6, they all increase hepcidin levels, and these block iron release from storage sites and reduce gut absorption. And this inflammatory process also suppresses erythropoietin production in the kidneys and induces bone marrow resistance to erythropoietin. And these combined effects lead to what we call functional iron deficiency, which is present even with normal or elevated iron stores. And then medication can also contribute, such as chemotherapy, and they can work via various mechanisms to drive the anemia. And then finally, another important cause is blood loss, and this can either be absolute blood loss, like bleeding, for example, or relative blood loss due to hemodilution. And the complexity of the etiology anemia that we can see here is then further compounded because these etiologies can overlap. And the optimal treatments for anemia are often influenced by the underlying etiology, which is where many of our challenges arise. So preoperative anemia is common, but is it bad? Well, this diagram illustrates the pathophysiology of anemia and why it is such a critical issue in children undergoing surgery. Anemia reduces the blood's oxygen carrying capacity, and the body compensates by increasing cardiac output, increasing tissue oxygen extraction, and altering hemoglobin oxygen affinity. So while these mechanisms will all help to overcome the reduction in oxygen delivery that we see in anemia, it results in decreased physiological reserve. And the combination of reduced oxygen delivery and decreased physiological reserve, combined with the increased oxygen demand during surgery, creates a perfect storm, leading to tissue hypoxia. This results in higher morbidity, wound infections, organ dysfunction, mortality rates increase, along with a greater reliance on blood transfusions, which, as we know, carry their own risks and costs. And these outcomes have been mirrored in the literature. We have observed that preoperative anemia in children has been shown to be associated with increased postoperative mortality, morbidity, and higher odds of perioperative transfusion. And these findings are not surprising because they reflect what we see in the adult literature, but they underscore the critical need to screen and manage preoperative anemia. So, how should we screen hemoglobin levels in the preoperative setting? Well, there are two broad options when it comes to measuring hemoglobin. We have point-of-care testing and laboratory methods, each of which have their advantages and limitations. Point-of-care testing provides us with rapid results. It's less invasive, more affordable, and requires less infrastructure. So it makes it ideal for the outpatient setting as well as resource-limited settings. However, its accuracy can vary across devices and environments, which in itself can create particular challenges. And certainly within our preoperative anemia clinic, our approach has been to verify the low HB level on the point-of-care testing with laboratory testing. Laboratory testing being the gold standard for accuracy. It's standardized and it also provides us with a more comprehensive analysis. But it is resource intensive, it's slower, it's more invasive, and it's more expensive. So the choice between each type of test used for screening will depend very much on the context in which it's used. Now, I want to discuss the challenges with identifying iron deficiency anemia. The gold standard is iron staining on bone marrow aspirate, but it's invasive and not practical for the preoperative setting. We can also use red blood cell indices like mean corpuscular volume, and they'll offer us some clues, but they lack specificity. So serum ferritin remains the most commonly used biomarker to identify iron deficiency. And in our anemia clinic, we've primarily used ferritin levels and/or transferrin saturation to assess for iron deficiency. However, The major challenge with most of the biomarkers is the impact of inflammation, which influences these markers. To overcome the impact of inflammation, we need to employ adjusted cutoffs, which is also a subject of debate in the literature. So some of you may be familiar with this. This is one of the most commonly used references, and it's the WHO cutoff values for diagnosing iron deficiency anemia, and they include thresholds and adjustments for the presence of inflammation based on CRP levels. However, as I've said, there's an ongoing debate about whether these thresholds are too conservative and whether we should be raising these thresholds to identify more patients earlier at the expense of risking overdiagnosis. So I think we're trying to find the right balance at the moment to refine our diagnostic approach. Okay, and for the final part of my presentation, I'm going to focus on the evidence-based strategies for managing preoperative anemia, and I'm going to begin with oral iron supplementation, because oral iron supplementation is without doubt a cornerstone of anemia management, in part because it's affordable and it's widely accessible. Although its evidence-based as the sole preoperative intervention as part of PBM in children is limited. In fact, there are 2 studies that have specifically described the use of oral iron in the PBM, in the pediatric PBM context. So the first study was by Switzer et al., and they looked at how preoperative hemoglobin levels influenced the likelihood of red blood cell transfusions after they'd introduced a PBM clinic and gave everybody preoperative iron, and this was children undergoing scoliosis surgery. So they found that almost half of their children received red blood cell transfusions, but if the HB immediately preoperatively was 14 or more, they were 84% less likely to require transfusion compared with those with levels of less than 12. And that was, when your level was between 13 and 14, you were about 80% less likely to need a transfusion. And they also found if your median duration of iron supplementation was shorter, was shorter in the transfused group. So this study sort of suggests to us that iron supplementation may play a role in optimizing hemoglobin and reducing transfusions. The second study, follow-up study after this, was by Atsuka and colleagues, and they looked this time at pediatric cardiac surgery patients. And they again implemented a PBM clinic and gave everyone preoperative iron. And then they compared outcomes between a group before they'd implemented the universal iron supplementation. And what they found was that the hemoglobin levels were significantly higher in the group after the implemented iron supplementation, but that didn't translate into a significant change in transfusion rates, although they did reduce the overall transfusion volumes. So again, suggesting that iron supplementation may optimize hemoglobin and reduce transfusion volumes. So the trouble or major issues we have inferring what to do with iron from these studies is they didn't do baseline HBs. So what we don't know is what the magnitude of the effect was, how much the hemoglobin changed, nor do we know what the prevalence of anemia was. They also did not have baseline iron studies, so we're not sure what the iron deficiency rates were within this group as well. They were also retrospective studies, which doesn't allow us really to establish causality, and they were single center studies, which limits their wider applicability. So now I want to discuss IV iron, which isn't used very much within the pediatric setting, and in fact, the current evidence for IV iron within the PBM setting is limited to adult studies. So within adults, a number of observational studies were done, and they all were quite positive, showing reduced risk of anemia, reduced transfusion needs, and reduced surgical risk. So understandably, the next step was to evolve and develop randomized control trials like the PREVENT trial, the FIT trial. But the results from these have been quite conflicting as to whether the IV iron is impacting on the outcomes that we are interested in. It does show us that IV iron has a good safety profile, certainly within the adults, with no major adverse effects reported. But at this stage, it's been a lot of effort to do the trials that are done, but we still need further trials really to confirm efficacy and guide practice. And certainly we don't have any within the pediatric setting. Erythropoietin has also been described as part of pediatric PBM as part of a bundle of care. Again, limited evidence for EPO in children. A lot of the studies or the studies introduce it as a bundle of care. And the current expert consensus suggests that we should be limiting its use for surgeries with high blood loss, like cranial synostosis and scoliosis. And it seems to reduce transfusions when used as part of this care bundle. But ultimately, it's expensive and there's limited availability. So at this stage, I think there's still space for more research to understand the role of EPO, certainly within the setting of anemia. And then finally, let's consider the role of patient blood management clinics. So patient blood management clinics play a critical role in addressing preoperative anemia. And at our institution, through the SAPSOS-2 study, we have successfully implemented a PBM clinic, albeit supported by research assistants. And this has allowed us to screen and treat a lot of children for preoperative anemia over a 2-year period. We hope when we share the results of this study, it's going to give us all an insight into how to develop a cost-effective PBM specific to our resource-challenged context. We hope to provide further insight into the role of oral iron as a primary intervention for preoperative anemia, and to provide some data on the incidence of iron deficiency anemia. So that brings me to the end of my talk, and I hope that my key message is simple. Do not ignore preoperative anemia. By focusing on screening and treating preoperative anemia, we hope that we can see improved outcomes in our children undergoing surgery. Thank you.
Good day, everyone. It is a pleasure to be here today. I'd like to begin by acknowledging the incredible presentations of Dr. Susan Goobie and Dr. Meyer, who have wonderfully highlighted how PBM in the pediatric setting can save lives and improve outcomes. So now let's explore how we can implement PBM effectively, even in resource-limited settings. I have no conflicts of interest to be disclosed. Over the course of this webinar, we've learned PBM offers remarkable benefits. For children, PBM is a game changer. As was described beautifully by our previous presenters, it is very important to outline that patient-related unique considerations, such as children's smaller blood volumes, make them more vulnerable to anemia and transfusion risks, and that their underlying pathophysiology and treatment thresholds differ a lot from those from the adult population, which means that applying PBM strategies is crucial to optimize care for them. The benefits of PBM are very well documented. PBM reduces transfusion-related complications, it minimizes dependence on scarce resources, and promotes more sustainable healthcare practices. So essentially, it conserves scarce resources and ensures better outcomes for children. But let's talk about what we need to do next. So what's next? It's time for implementation. But implementing PBM sounds ideal, but the how can be very, very tricky. Implementing PBM, especially in limited resource settings, comes with its own set of challenges. And what are some of the common challenges faced in these settings? Well, first and foremost, we often see infrastructure deficiencies, limited access to blood products, essential diagnostic tools, and a shortage of trained personnel. Without a solid foundation of resources, implementing PBM can feel like a tall order. Second, financial constraints. Financial constraints cannot be ignored. PBM interventions such as iron supplements and erythropoietin, they all come at a cost. While they're cost-effective in the long term, securing the initial funding remains a big challenge. Lastly, there are cultural and institutional barriers. Many institutions are still rooted in transfusion center practices, and PBM may face a lot of resistance. There is also limited awareness of the long-term benefits of PBM. These are all significant obstacles, but they are not insurmountable. So how do we address these challenges? And the answer is addressing them with individualization. The key is individualization. Any new standard of care, particularly one like PBM, must be tailored to the local context. PBM programs must adapt to local conditions, to available resources, and to cultural norms to be effective. It's not about applying a one-size-fits-all approach. It's about designing programs that fit the unique needs of each healthcare setting. And how do we design this unique strategy? Well, we use several key steps to build our own and unique strategy. We need to remember that we need all of these steps. We need to approach our hospital leadership to get a buy-in, identify PBM champions, and establish working groups to guide the process, promote education, and encourage multidisciplinary teamwork across the departments. We need to develop also locally adapted protocols for the 3 key pillars of PBM. Establish partnerships and networking with local, national, and international organizations. We need to invest time and effort in research to demonstrate positive outcomes of PBM. We need to engage community to raise awareness and foster support, and we need to involve government authorities to secure long-term policy support. All these strategies don't need to be implemented in a strict order. They can happen simultaneously or sequentially, depending on your hospital needs. Some experts suggest that they can be even more effective when they are bundled together. We will now make room for some tips and tricks when working on each of these key steps. So we will start with approaching hospital leadership. When approaching hospital leadership, it is important to present PBM as a cost-benefit program. Highlight the potential to reduce dependency on blood transfusions, on decreasing transfusion-related complications, and to improve patient outcomes, especially with shorter length of stays. Start by identifying the main PBM issues in your hospital and then propose incremental implementation. Begin with small-scale pilot projects, ideally in only one department in your hospital, and then use the positive results to advocate for hospital-wide adoption. Then, an essential step is to identify PBM champions in your hospital, in your town, in your nation, in your society, individuals who are passionate about PBM and can advocate for its adoption. So we need to train non-specialist providers on the basics of PBM and anemia management. This includes task-shifting responsibilities such as anemia screening, nutritional counseling, and postoperative monitoring. Moreover, organizing leadership workshops for administrators and other stakeholders. This can help build awareness and get support. Offering both online and on-site training for pediatrician and other relevant specialties can also ensure PBM become ingrained in everyday practice. So PBM is also typically divided into 3 key pillars. And these 3 key pillars also have different phases. We have the preoperative phase, the intraoperative phase, and the post-op phase. So what things can we do in our limited setting in each of the different pillars? Well, we can begin by using simple and cost-effective tools. Remember, we can make it simple, like colorimetric hemoglobin strips or whatever comes very cost-effective in your location. Simple strategies, like for example, also every child scheduled for surgery should receive iron supplementation well in advance, at least 3 or 4 weeks prior to elective surgery, no matter if they have been screened or not for anemia. Due to the high prevalence of iron deficiency in our regions, iron supplementation will not be detrimental if not needed, but very beneficial if needed. Team up with pets for iron supplementation to every child scheduled for surgical procedure. For pillar 2, the goal is to minimize blood loss and using meticulous techniques and use of antifibrinolytics. The routine prophylactic use of tranexamic acid for procedures that will have significant blood loss is very important to emphasize for the in-hospital administration and to make it part of the protocols in the institution. Also to additionally limit unnecessary blood samples and use pediatric size collection tubes. Additionally, establish restrictive transfusion protocols, setting clear thresholds for when transfusion is necessary. And also this can be done by adapting protocols to existing hospital or your institution protocols. In the pillar 3, you can postoperatively, we need to monitor recovery closely, focusing on the adequate nutrition and continue anemia management. And as you can see, start with small changes. Don't you want to make a start acquiring new and big and important equipment? If you do not have a cell saver, probably in our regions or in very limited resource settings, it's going to be very difficult to acquire. You will have your chance to do that. But first, start with small steps that don't necessarily cost a lot. And these small changes will start making big differences. And these big differences will allow you to have a voice. And then you will be able to escalate and ask for more resources. So next, implementing PBM in resource-limited settings. Definitely is not a task you should do alone. You will not and cannot do this on your own. So collaboration is definitely the key. Partnering with non-governmental organizations, global health organizations, and local governments, also with local societies, whether it's anesthesia societies, pediatric societies, they can all provide vital resources and expertise. Joining forces with groups like the World Society of Federations of Anesthesiologists and local societies can help advocate for PBM and ensure that implementation is supported on a broader scale. We must also focus on demonstrating PBM's positive outcomes. Start with pilot projects in pediatric surgery departments, track baseline data, measure key metrics over time to showcase the effectiveness of PBM. And by collecting and sharing this data, we can demonstrate the impact of PBM on patient outcomes and encourage a broader adoption. For example, on this data in metrics article, I really liked it. In order to assess PBM's effectiveness, this recent study outlines 65 data elements and categorizes them in 36 outcome metrics to guide hospitals in assessing PBM effectiveness. This practical framework helps institutions tailor their data collection strategies based on their resource and their goals. So, another important information that this article highlighted was given a 3-category systematization of metrics or data to be collected. We can choose according to our institution capabilities if we can access the basic level, intermediate level, or advanced level. There are obvious limitations in many low and middle income countries, such as lack of standardized methods to accurately measure blood loss, limited patient data, unreliable transfusion times. The absence of data collection system really makes it difficult to assess anemia severity or track transfusion practices. These are all very significant barriers, but they can be overcome with strategic planning and support. Start first with a basic level gathering of information. Sometimes all this information, if you don't have electronic data collection system, they are probably already in registered by hand. But these usually information that are gathered in the basic level, they are found somewhere in registries in your hospital. So start from there. And next, also we need to remember that in these settings, community is very important. So community engagement is crucial. We need to raise awareness about the importance of PBM in pediatric care through local outreach, workshops, advocacy campaigns. When community supports PBM, there is a greater chance for a long-term success. So then engage the public either with radio programs for rural areas or conduct public awareness campaigns, and also engage all traditional healers and community leaders. Social media has become very important. Social media and publications are very powerful tools in spreading the word. So many professionals and organizations are now sharing success stories and research throughout these platforms. So follow and engage with them and motivate others to follow and engage to stay updated on new findings and innovations of PBM. Lastly, involving government authorities is very essential. PBM must be seen as a sustainable solution that can help reduce healthcare costs while improving outcomes. So invite government officials to workshops, webinars, or boot camps to raise awareness and capture the attention of people involved in healthcare ministry or national institutions, and they will start to get involved and foster policy changes that support PBM adoption at a national level. Many countries are right now at different stages of PBM implementation. But the important thing is that we are not alone in this effort. There is a global movement towards PBM, with countries like Kenya, Honduras, Philippines, Morocco, India trying to implement PBM in their hospitals and national policies. Many other countries are far advanced in protocols and strategies, but if they could do it, so can we. I know there is a lot of other countries. I'm sorry if your name is not on the screen, but I know there's a lot of countries that are way ahead. But if they could do it, so can we. So we need to inspire ourselves from all these first world champions and follow their lead, adapting, of course, our own strategies to our local needs. And I would like to conclude urging each of you to become advocates for PBM in your own settings. While challenges, I know they do exist, strategic and locally adapted implementation can overcome any barrier and save lots of lives, even in the face of limited resources. So together, we can make a significant impact on pediatric care and improve outcomes for the most vulnerable patients. Thank you so very much for this time, for listening, and this is my QR code for all the references.
Thank you, Maria, and thank you, Heidi. I'd like to now conclude our three speakers, and I would like to welcome you to submit your questions. We have about 15 minutes, I think, where we can chat and talk about questions. There was a number of different questions about can you share the presentations, and about the certificate. And just to mention, yes, each of you who've signed up, you will get a link for the YouTube video of this, and you will be able to have access to our talks and the slides from that link. And also you will get a certificate of attendance from the WFSA. So thank you for joining us. In a second, I'll take some questions. But first, I really wanted to mention two things. One is we have a wonderful collaborative with the WFSA. We have a pediatric PBM working group, and we've been doing a lot of work. And at the upcoming World Congress, we will have some opportunity to meet and discuss pediatric PBM initiatives. So I think there's a slide about the World Congress and some information about that, which I'll share in a second. Also, I'd like to introduce you all to SABM, which is the Society for the Advancement of Pediatric or Patient Blood Management. Sorry, I definitely have pediatrics on my mind. I'm a member of SABM. I've been for a long time, and we do some very good work in the patient blood management realm. And we would enjoy and welcome you all to check out SABM, who are now collaborating with the WFSA. So SABM is a really good resource if you have any questions about patient blood management and if you'd like to join our members. So please submit your questions via the Zoom. I'm going to start I think Dr. Meyer. Oh, there you are, Heidi, you got on.
I'm sorry, my video was off there.
Yes, there was a couple of questions which I'd hope you don't mind if I ask you.
Sure.
And it was specifically with regards to preoperative anemia. And there was a question there about asking what would be your hemoglobin cutoff for diagnosing and treating preoperative anemia? What would be your comfort level? And and how would you approach managing that patient if you needed to postpone? Would you give IV iron, PO iron? How do you make your decisions?
Sure. So I think I also saw that pop up in the chat. So we use, I mean, there are different definitions for anemia, but we use the WHO definitions. And actually, they've just last year published some updated definitions for anemia. So what they've done is in the younger age group, 6 months to 5 years, they've actually split that further. So I did put a link in the chat in the answered section. So with the link to that document from the WHO, so that's what we use, and that will depend on the age of the child. And then in terms of iron deficiency, we also use the WHO definitions, which I put in my presentation. I also put the link in the in my answer as well. Having said that, there's some really good work by a group called the Brinda Project, and they're particularly looking at these biomarkers in the setting of inflammation. And they've published some nice studies within the African context. And that's from that we've used transferrin saturation levels as well as ferritin levels. So bearing in mind, as I talked about, the problem is this inflammatory process impacting on the biomarkers. So how we approach preoperative anemia, we do a capillary blood test, and if they're anemic, what we do is we do formal laboratory tests, because we have those, and we confirm that they are anemic, and then we look at the ferritin, and the TSAT level we use is 11%. That's based on the Brinda study. And then if they do meet the criteria, then we give them up to 3 months oral iron. And that's what we've been doing. More practical approach. So within the primary healthcare setting in South Africa, what happens there is if a child is anemic, they just get assumed to be iron deficient, and they get dewormed if they haven't been dewormed in the last 6 months, and they start them on oral iron, and they bring them back a few weeks later and make sure that the hemoglobin is improving, and then everyone's happy. We've got the diagnosis and we are treating it. In terms of delaying for surgery, that's quite a difficult one to answer, because it will be quite specific depending on the patient and the context and the urgency of the surgery. So just broadly speaking, maybe it's very elective surgery, but it's incredibly minor surgery versus major urgent surgery, and that's going to influence the decisions around that. In terms of thresholds, we'd still use the same transfusion trigger thresholds. I think that's probably...
I think you've answered every one of the questions that I added. So thank you very much.
Yeah.
No, great answer. And, I agree, in the United States, we don't feel that we're ahead of the game. We're not. I have to say that most of our patients, because we have such a large center at Boston Children's Hospital, are seen the week before surgery. So there was a question there about how do you collaborate with your surgeons? This is what I've done for our highest risk patients, our craniosynostosis patients. I've collaborated with our surgeons to now get the blood work at the time that the surgeon sees them in the clinic to book for surgery. We get the screening blood work then, because I say, we're going to cancel if you don't help me manage this anemia, because at our hospital, about 25% of our children are anemic preoperatively. So we've been really kind of working from the bottom up with our surgeons to get this highest risk population to actually treat them with PO iron. And we've been showing results with just that simple intervention, no IV iron, no, nothing fancy. But we have about 6 weeks before they come for surgery usually. And just by implementing oral iron and changing the diet, if they're on formula, supplementing with drops, maybe iron drops, it's made a big difference. So yes, please get your surgeons involved. It's always good to threaten to cancel. Maria, what about you?
Yeah, may I add something? Sometimes also surgeons,
Absolutely.
I don't know how is it in your country, but in my country, some hospitals do change the surgical specialty that is giving the consultation. So one of the things that you can do is grab the non-specialist personnel like nurses, because they are usually not interchangeable. They are usually always the same personnel staying in the consultation. So train them to also, if they get a child for for surgery that's going to be major surgical bleeding loss, get her to make the surgeon do what he has to do for PBM, so also get everybody on board.
Right. Just to correct you, surgeon can be him, her, and nurse can be
Yes,
she, him.
sorry about that.
We're celebrating our all women team here today, so I had to just note that.
Yes.
We have 5 minutes left. Maria, there was a question about, and I think this is a really important one, because in resource limited settings, maybe with poor laboratory screening or poor resources, what is your perspective regards to the goal of, or the role of goal-directed bleeding management and transfusion management?
That is a great question, because yes, in low research settings, we do not have point of care. We do not have viscoelastic testings. So we have to go back to the basics. I will take a phrase from you, Dr. Susan, that says, take, your patient, treat the patient, not the number. So, clinical, you have to go to your signs and symptoms. If you are with a patient in your surgical room, then look for signs of low perfusion, slow capillary refill, or low urine output, hypotension, tachycardia. You'll know that your patient is not tolerating anemia well, and you have an active bleeding. So you'll know when to transfuse, and you'll know if your patient clinically is tolerating the blood loss till that moment, right? And the best thing to do if you do not have point of care is to prevent, to grab your patient before. And if you know the surgery is going to be a lot of blood loss, then plan it well. Do not proceed if you have an anemic patient. Prepare before and do your oral, supplementation of iron for children. So go back to the basics.
I think that can work anywhere in the world. Treat the patient, not the number, and go back to the basics. And I would like to highlight patient-centered care and patient-centered decision-making. We're all here because we want to do the best for our patients. We want our patients, particularly our pediatric patients, to have the best outcomes. And we need to involve them in the decision-making process at all times. So that can't be emphasized enough. That's a very, very important part of patient blood management, is that it should be patient-centered and family-centered. So I think we've come to the end of our webinar. I'm gonna ask my co-panelists if they have any other comments to make. And I want to really thank the WFSA for inviting the three of us to talk today about pediatric patient blood management. I apologize, we can't get to all of your really excellent questions. I'm hoping maybe that we could save the questions from the chat and somehow maybe in an email answer some of the more common ones would be really nice. I hope you enjoy watching the video again. There are some QR codes and some links, and there's a lot of information in there together with our references. So on behalf of the WFSA and my co-presenters, have a wonderful day and take care.